Often called the immune system, the lymphatic system is a better name because not all of its functions involve immunity, but essentially all of its organs transport lymph or produce lymphocytes. Lymphocytes are one of the 5 types of circulating white blood cells where they play various roles in body defense. While they are developing in various lymphatic organs, lymphocytes and their stem cell precursors produce the defensive proteins called gamma globulins, or antibodies. Lack of specific antibodies is why a first grader exposed to chickenpox develops the disease. Subsequent production of antibodies against the chickenpox virus is why that same first grader is unlikely to contract chickenpox again.
Hi, I'm Mike Shively, and this is Introduction to Anatomy and Physiology. In a previous session, we talked about fetal circulation, and we went over it kind of hurriedly. Do any of you have any questions in regard to that? Starley?
I was just wondering how the foramen ovale closes fits due to the higher oxygen.
No, the foramen ovale closes due to a different mechanism. Most of the peculiar structures related to the fetal circulatory system do close due to higher levels of oxygen, which causes smooth muscle in their walls to contract down. But if we go to the overhead camera for just a second here, we'll take a look at the heart. And the foramen ovale is actually a interatrial septal defect. A little flap comes out here to allow some of the blood here in the right atrium to go through directly into the left atrium and thus bypass the lungs. Well, after the neonate starts breathing on its own, the venous return into the left atrium tremendously increases simply because there's more blood coming back from the lungs. And as all this blood comes in, it increases the pressure within the chamber of the left atrium, and that physically swings this little trap door, this little flap of tissue back over, and closes it. It's kind of like a screen door being blown closed or, by the wind. And that functionally closes the foramen ovale, and then what happens with time is fibrosis or scar tissue formation then permanently closes this. So the foramen ovale of the heart is the one fetal structure that does not close during or right after birth due to higher oxygen levels in the bloodstream. Any other questions? Adam?
So if that stays open, is that a life-threatening condition, or?
Usually, a foramen ovale, what we call a patent foramen ovale, or one that remains open and fails to completely seal close, is not, in most cases, a serious problem, simply because the pressure in the left atrium and the right atrium in the child and the adult is about the same. And as a consequence, even though there may be a small hole between those two chambers, there's no real tendency for blood to flow either direction, from one to the other, or the second back to the first. Now, patent ductus arteriosus, which is that little vascular channel that connected the pulmonary trunk to the aorta, that's a quite serious matter, causes serious circulatory disturbance, and is a major cause of the quote, blue baby syndrome. Causes a machinery murmur, and typically they watch those very closely, and many times may have to surgically correct them by going in and tying off the ductus arteriosus if it fails to close within a few hours or a day or two after birth. Any other questions? Today we want to talk about the lymphatic system and a little bit about immunity. And in the pre-taped video segment, it mentioned that this system is often called the immune system, but probably the better name for it would be lymphatic system, since all of the components do either produce lymphocytes or carry the fluid that we call lymph. Let's make a list. Let's just go around the room here and think of things that belong to the lymphatic system. We'll start over here. Starley, name something that's a component of the lymphatic system.
Lymph nodes.
Lymph nodes. Okay, they're about 200 or more, depending on how you count them. Many of them are quite small. Lymph nodes scattered throughout the body. Those are a component. Seth?
Lymphatic vessels.
Lymphatic vessels. Most of the lymphatic vessels are not named. The smallest ones we call lymphatic capillaries, and they drain into larger lymphatic vessels, which drain finally into some vessels that are big enough to have names that we call trunks, lymphatic trunks. And then there are some really large ones that we call the thoracic duct and the right lymphatic duct. Eva?
Tonsils?
Tonsils. Tonsils are aggregations of lymphatic tissue found in the pharyngeal region, and there are actually several sets of them. as many of you may know. Adam?
The spleen.
The spleen is the largest individual lymphatic organ. It's located in the abdominal cavity along the greater curvature of the stomach. On occasion, due to a sharp blow to the abdominal region, it can be ruptured. A sharp blow might include not wearing your seatbelt and getting slammed up against the steering wheel. And spleens are kind of difficult to suture back together. They're not vital organs, and so in some cases of splenic rupture, the surgeon may elect to simply remove the spleen itself, because there's several other lymphocyte-producing organs in the body. Amber?
Lymph that flows through the vessels?
Lymph itself we could consider to be a component. Lymph is a fluid that it has such a low cellular content that we don't usually consider lymph to be a tissue, simply because the cellular content is so low, but we could consider lymph to be a component of the lymphatic system. What else? Bryce?
Would you consider lymphocytes?
Lymphocytes themselves, certainly. Those are products of many of the lymphatic organs. Let's take a look at a graphic that summarizes the components of the lymphatic system and see if we've got most of those listed when we're around the room. Lymphatic vessels we mentioned, lymph nodes, spleen, the thymus. I don't believe anybody mentioned thymus. Kind of an intriguing organ. We'll talk about it in a little bit. It's fairly large at birth, and it continues to enlarge until about puberty. And then it undergoes involution and basically completely disappears. It's difficult or impossible to find any thymic tissue in an adult. Tonsils we mentioned, and then there are also some subepithelial aggregations of lymphatic follicles that are found especially in the lower part of the alimentary canal. These have previously been called Peyer's patches. In your reading you may have come across that term, P-E-Y-E-R-S, Peyer's patches. So these are the kinds of things that we think about when we think about the lymphatic system. And what does this system do? First of all, I want to make the point that the lymphatic system is sometimes left out when we list all the body systems. You know, if we kind of compress that list, we could leave the lymphatic system out with the idea that we've included it when we listed what other system. What system is it most closely related to? Starley?
The cardiovascular?
Cardiovascular system. The lymphatic vessels, the largest lymphatic vessels, drain into some of the large systemic veins. So lymph, which is collected and returned to the circulating bloodstream by those vessels, all drains back into blood vessels eventually. So the term cardiovascular system can include the lymphatic system, although in most cases we'll separate it out and list it in its own right. All right, what kind of things does it do? Functionally, what does this system accomplish for our body? Bryce?
It collects the excess fluid that leaks out of the capillaries.
We mentioned when we were talking about the cardiovascular system that capillaries are leaky, that their walls are so thin that there's some fluid that seeps through. Now, we didn't say it was blood going through the wall of a capillary. We said it was water, organic molecules, electrolytes, small organic molecules and electrolytes. Blood cells and blood proteins, by and large, do not leak through. But that is a continual process and happening all the time. And if it weren't for lymphatic capillaries to pick up this excess tissue fluid, interstitial fluid, then we would basically lose all of our blood volume and we would swell up like ticks. Adam?
How does that fluid differ from actual blood plasma?
Blood plasma, of course, has a lot of protein in it and larger organic molecules, and interstitial fluid has very little in the way of protein or larger organic molecules. That's the big difference. Okay, so one of the things it does is it collects this excess tissue fluid and returns it to the bloodstream. What else does the lymphatic system do? Seth?
It produces lymphocytes.
Produces lymphocytes. Now, lymphocytes are one of the 5 kinds of circulating white blood cells. And there are actually 2 big categories of lymphocytes, the B lymphocytes and the T lymphocytes, which we'll say something about a little bit later. But a lot of the lymphatic organs actually produce lymphocytes. And those lymphocytes, in turn, are one of the cells that produce antibodies. Lymphocytes and some of their related cells produce antibodies. Antibodies are defensive proteins that our body produces. And those proteins give us immunity to certain pathologic conditions, certain diseases. All right, another function of the lymphatic system. Eva?
It exposes developing lymphocytes to antigens.
Well, from a functional standpoint, that's exactly true. The lymphocytes and their precursor cells are exposed to foreign proteins called antigens, and as a result, those cells do produce the antibodies. One other kind of a peculiar thing that the lymphatic system does, Adam?
Doesn't it absorb lipids?
It's kind of intriguing that most nutrients, when they're absorbed from the alimentary canal, most nutrients go into blood-type capillaries, regular capillaries. But the lipid materials have a predilection to go into lymphatic capillaries. So most of the lipids that are absorbed from the alimentary canal are actually absorbed into lymphatic capillaries. And of course, after those lymphatic capillaries join larger lymphatic vessels, that lymph is eventually, carrying those lipid materials, is eventually dumped back into the circulating bloodstream. But that's true. Let's look at a graphic that summarizes what we just said then. The functions of the lymphatic system are to collect excess interstitial fluid. This stuff is sometimes called tissue fluid, interstitial fluid, extracellular fluid, we could put here just as easily, and returns that excess fluid to the bloodstream. Another thing the lymphatic system does that we mentioned is produce lymphocytes, which in turn, as Eva mentioned, produce antibodies. And finally, the lymphatic system is involved in the absorption of lipids from the alimentary canal. Now let's see if we can take a look at how the lymphatic system is involved in absorbing excess tissue fluid. I want to go to the overhead camera, and we're going to draw what looks like a football goal post here. But we're going to say that this is an arteriole. And this is a venule. What would that make this, y'all?
Capillary.
This must be a capillary. We can put a little precapillary sphincter on here. We want to be anatomically and politically correct. Now, blood flows from the arteriole through the capillary, and then the capillary drains into the venule, and of course then that venule carries the blood into larger veins, and that returns the blood back to the heart. So this is just a standard blood-carrying capillary, a regular capillary. But as that blood flows through this capillary, some of the water, electrolytes, and small organic molecules leak through the wall. A slow but continual leakage. And as that material leaks through the wall of the capillary, then it becomes interstitial fluid, or tissue fluid, or extracellular fluid. Now, where that goes is into the ends of lymphatic capillaries. I'm going to draw a lymphatic capillary down here. And of course it drains into a larger lymphatic vessel. What do you notice right away about this lymphatic capillary? Adam?
It's not a closed system. It actually ends in like a sac instead of connecting.
Okay, this is a dead-end street. Okay, this street's dead end. A regular capillary is open at both ends, one end attaching to an arteriole and the other end attaching to a venule. A lymphatic capillary is a blind-ended vessel, and there's no blood inside of it. The excess tissue fluid enters it, and as soon as that tissue fluid enters through the wall of that lymphatic capillary, we call it lymph. So when the fluid is out here, we call it interstitial fluid. As soon as the fluid goes through that lymphatic capillary wall into the lumen of the lymphatic capillary, it becomes, by definition, lymph at that point. And then that lymph it flows into larger, I said larger lymphatic capillary. Let me make this larger lymphatic vessel. Flows into a larger lymphatic vessel, which then, of course, goes into still larger ones, and then we'll talk about some of the bigger ones here in just a moment. But that's basically what is going on a continual basis. Now, let's suppose we go out to the, over here to the gym and play a game of handball, which is basically racquetball where you forgot the racket and you're just whomping the ball with your hand. Has anybody ever played handball? Any of you ever played handball? You've played it, Starley? What about your little hand after you get done with a game of handball?
Red and sore.
It's red and sore, and maybe a little puffy, and it's kind of hard to make a real tight fist because it's swollen up. What happens in those conditions is we're actually physically damaging, doing some little micro damage to some of the capillaries and making those capillaries even leakier than normal. So excess, a larger amount of fluid seeps through the capillary walls. So our hand swells up a bit. That's what's going on there. And of course, there are some other conditions that can alter the dynamics of what's happening here at the capillary are very critical because there's several different pressures, if you will, that are acting. First of all, as the blood flows through the capillary, there's the physical blood pressure against the inside of the capillary wall that's pushing outward, trying to force fluid through that wall. And remember that capillary walls are semi-permeable. And there's also an inward pressure from the tissue fluid that's outside the capillary, pushing back in against it, but it's a much smaller pressure out there. And then there's some osmotic pressures. You remember, can somebody define osmotic pressure? What do we mean when we say osmotic pressure? Eva?
It's just kind of the movement of a fluid from a high concentration gradient to a low concentration gradient. So it's moving to a place with more solute in it usually.
Okay, and what fluid are we talking about when we talk about
water?
Water. Let's go to the overhead camera for just a second, because I want to just complete this idea about why capillaries leak. Let's say this is a beaker, and I'm going to put a semi-permeable membrane in here. It's going to be a stiff semi-permeable membrane to divide this beaker into the left side and the right side. Over here on this side, I'm going to fill it up to right there with just plain water. Over on this side of the beaker, I'm going to put water in there, and then I'm going to put some sugar. Just a teaspoon of sugar, okay? Now, this membrane will allow water molecules to pass through, but it will not allow sugar molecules to pass through. What's going to happen with a little bit of time?
Water's going to go towards the sugar.
Water's going to move to the right. So this meniscus here will actually go down because some of that fluid, some of that water will move from this side through the membrane over to this side, and this one will actually go up. So all things being equal, if that membrane were stiff enough to stand the strain, we'd actually have a net movement of water from over here to this side, yes? Mm-hmm. All right, blood is like this side. It's water with a lot of other things in it. Interstitial fluid is water with a few things in it. The more non-water things that are in a fluid, the higher the osmotic pressure of that fluid. So if we go, let me go back to this capillary again on the overhead camera. We've got the physical pressure of the blood pushing against the inside of the capillary wall, call that plasma hydrostatic pressure. We've got the physical pressure of the interstitial fluid pushing back the other direction. But this is a very small pressure. This is a fairly large pressure. Then we also have osmotic pressures on each side that are influencing the direction that fluid moves. At any rate, when we add up all of the pressures that are acting on that fluid as it goes through the lumen of the capillary, the total out pressures exceed the total in pressures. And with the capillary wall being as thin and permeable as it is, there's a net leakage or a net movement of fluid from the lumen of the capillary into the extracellular environment. That stuff becomes, again, interstitial fluid or extracellular fluid. And when that fluid is absorbed into a lymphatic capillary, that same fluid becomes lymph by definition. Does that make sense on what's going on? Anyway, that's where lymph comes from. Now, I want to talk about the larger lymphatic vessels. Most lymphatic vessels have no names at all. We don't have names for them, but there are a lot of them. They're very, very thin-walled. They physically resemble thin-walled veins structurally. They've got the same layers in their wall and so forth, but they're very, very thin-walled. But there are some names for some of the very largest lymphatic vessels. Let's go to the overhead camera here, and we'll draw a little person. There are actually two lymphatic vessels that carry lymph down the neck from the head. There are, well, I'm going to put a number 1 there, and there's two that are involved in carrying lymph in from the superior limbs. So I'm just representing those by black arrows. We'll call those number 2. There's a couple that drain lymph from the chest area. We'll call these number 3. There's a bunch of them down here in the abdominal region. We'll call those 4. And then there's a left and right version carrying lymph back up from each inferior limb, and we'll call those 5. Okay? These number 1s up here are the left and right jugular trunks. Left and right jugular trunks. And they carry lymph down from the head, carry it down the neck. Number 2 are the left and right subclavian trunks. Maybe I better write those words. One is jugular. I'm going to write TR. The left and right jugular trunks, number 1. Number 2 are the left and right subclavian trunks. Number 3 are the left and right bronchomediastinal trunks. Those are the ones that drain the chest area. Number 4, these over here are called intestinal trunks. They drain abdominal viscera. And number 5, these are the left and right lumbar trunks. They actually come from the inferior limbs, but they get up into the lumbar region. So that's where they get the name lumbar. Now, if this person is facing us, okay, having a good day, got a smile. So we'll say this is that person's right side, and this is that person's left side. All of these trunks that are on the left side of the body, including all the intestinal trunks, and even this one, I'm going to put a circle around all of these arrows right here. All of those actually drain into one large lymphatic vessel that's called the thoracic duct. So everything circled goes into what's called the thoracic duct. That's actually the largest lymphatic vessel in the body. These other 3 right here, the right jugular, right subclavian, and right bronchomediastinal, these drain into what's called the right lymphatic duct. So we end up, when all of these get coalesced into the larger vessel into which they drain, we end up with 2 relatively large lymph-carrying channels. And I want to bring up a model and lay it up here. It's a pretty big model. Overhead camera may have to back up a bit to see it. The white lines on this model actually represent lymphatic vessels. Again, most of these don't have names. These small yellow structures are actually lymph nodes. We'll talk about those in just a moment. They're located along the course of lymphatic vessels. And I want to draw your attention to this large white line here. This is the thoracic duct. That's the largest lymphatic channel in the body, drains again all of the left side of the body, including the abdominal region, and both inferior limbs. And it actually empties into this venous channel right here. This is, it either empties into the brachiocephalic vein, which is the combination of a subclavian vein and internal jugular vein, or it dumps into the subclavian vein or the internal jugular vein itself. It varies from one individual to the next. The other large lymphatic channel is represented over here. This is the right lymphatic duct. And as you can see, it's emptying typically into the right brachiocephalic vein at this point. And all it drains basically is the right half of the head, the right superior limb, and the right part of the thoracic area. So those are the two largest lymphatic channels. And the point that I want to make here is that all of that lymph is actually going to drain back into the circulating bloodstream. Along its course, of course, the lymph does go through maybe a series of several different lymph nodes. So as the excess tissue fluid is collected, it becomes lymph, it does return to the circulating bloodstream. Let's go to a couple graphics here and summarize some of the comments we've made. We'll look at a graphic that talks about lymphatic capillaries. Remind ourselves that they are closed on one end. They do not hook up to blood vessels at all. The other open end drains into a larger lymphatic vessel. They absorb interstitial fluid, and then they are obviously involved in transporting that fluid. Once that fluid is absorbed, we call it lymph. The larger lymphatic vessels, if we look at the next graphic, most of them are not named. All of them on the left side of the body, and those on the lower right side of the body, drain into the thoracic duct, and those on the upper right part of the body drain into the right lymphatic duct. And these two vessels, these two large lymphatic vessels, drain into the very large venous channels just above the heart. So that's how that lymph gets back into the circulating bloodstream. Okay, let's consider the other lymphatic organs. We've talked about lymphatic vessels for a bit. Let's talk about lymph nodes for a little bit. Let's go to the overhead camera, and we'll draw a facsimile of a lymph node here. There are actually incoming lymphatic vessels which carry lymph into the lymph node. These are called afferent lymphatic vessels. So they're bringing lymph into the lymph node. And there's typically one or sometimes more efferent lymphatic vessels which carry lymph out of the lymph node. So the lymph actually percolates, if you will, or filters through the lymph node. I'm just going to write the words afferent up here and efferent down to the bottom to represent the incoming and the outgoing lymphatic channels. The lymph node itself, there's a capsule, a connective tissue capsule around it, and the substance of it actually consists of kind of spherical groups. I'm just going to draw some little funny things in here, okay? These are representing groups of developing lymphocytes. And each little group of developing lymphocytes is called a lymphatic nodule or lymphatic follicle. So there'd be a whole bunch of those groups of developing lymphocytes within that one lymph node. Now, lymph nodes do vary quite a bit in size. Some of them are basically so small that you have trouble seeing them, up to ones that are just a few centimeters across. At any rate, the developing lymphocytes, as they mature and complete their development, they actually turn loose of their group and flow with the outgoing lymph into the efferent lymphatic channel. And in that manner, those mature lymphocytes finally enter the circulating bloodstream. But while they're undergoing maturation, while they're developing here in these nodules within the lymph nodes and other lymphatic organs as well, they're actively producing antibodies. So developing lymphocytes are active antibody producers. Now, a given droplet of lymph coming in an afferent lymphatic vessel here may go through this lymph node, goes out this efferent lymphatic channel. It may go through other lymph nodes on the way back to the circulating bloodstream. So a given droplet of lymph may encounter a number of lymph nodes in its journey back to the circulating blood. Any question about lymph nodes? Now, some of you have probably had some enlarged ones, you know, and particularly these, when you have a real sore throat, sometimes the lymph nodes that are located in the cervical region here on the side of your neck will enlarge. And once they enlarge, they get kind of painful when you press on them. They hurt a little bit. The enlargement is due to hypertrophy of these groups of developing lymphocytes in response to the infectious process. Those lymphocytes are attempting to produce defensive proteins, gamma globulins, antibodies against that infectious process. Do you have a question, Starley?
I was just wondering, because there are so many more afferent lymphatic vessels coming in and only 1 or 2 efferent, are they larger?
I think the efferents tend to be bigger than the afferents, yeah. So we got a lot of smaller ones coming in and bigger ones going out. But you realize this channel right here, this efferent lymphatic channel, will become an afferent to the next lymph node on the way. So it's a relative thing, right? Once a lymph node does enlarge, even though the pain may eventually go away, they rarely shrink completely back down to their original size. So some of you may have, you know, quote, hard knots that you can feel along the side of your neck here, where you've had some previously sore lymph nodes that you can still palpate. Next lymphatic organ I want to talk about just a moment is the thymus. And I want to bring up a model here and put on the overhead camera. Of course, when you look at this model, you say, well, that's a heart. Well, yes, it is, but this structure right here is the thymus. And it consists of a left lobe and a right lobe, and they're just kind of stuck together in the middle with no interconnecting isthmus like we saw in the thyroid gland. When a neonate comes into existence, the thymus is relatively large, and it continues to enlarge up through about puberty, reaches its largest size at about puberty, and then it undergoes involution, or it regresses, and by the time we're full-sized adults, the thymus basically cannot be found. Now, what's going on here is that the cells, the modified lymphocytes that are developing within the thymus, happen to be called thymocytes. Those modified lymphocytes are actually seeding out into other lymphatic organs. The thymus is the source of the so-called T lymphocytes in the circulating bloodstream. And so those precursor cells, while we have a thymus, you know, as a neonate and a young person, while we have a thymus, those precursor cells then seed out into lymph nodes and bone marrow tissue and so forth. And it's those cells originally derived from the thymus that give us the quote, killer T cells and other types of T lymphocytes. And that's about all there is to say about thymus. You won't see one down in the anatomy lab on a cadaver, simply because they don't exist basically in the adult. Let's go to tonsils, and I've got another model that we can look at on the overhead camera here for this. This is a mid-sagittal section through the head. You can see a brain up here and recognize a nose and a mouth and a tongue perhaps here. And I'll call your attention to this tissue right in here. That's tonsillar tissue. This is tonsillar tissue right here. This is tonsillar tissue. And there's even some tonsillar tissue right around this opening. Anybody know what this opening might be? Eva, what is this?
That's the opening to the auditory tube.
This is the pharyngeal opening of the auditory tube. That's that little tube that connects the cavity of the middle ear to the pharynx. And you can't see the tonsillar tissue because it's buried beneath the mucous membrane here on this model, but the reality is there's some tonsillar tissue there. It's called tubal tonsil. This back here is called pharyngeal tonsil. This down here is the palatine tonsil, and this is lingual tonsil embedded in the base of the tongue. Now, the palatine tonsil is the only tonsil that you can see when you open your mouth big time in front of a bathroom mirror and look back there, okay? So if you haven't had this experience, this will be one for you. Go to your favorite bathroom, open up wide. You may need a flashlight to assist in this particular exercise, get a little light back in there. And on the sides of the gullet, basically pharyngeal region back there, you'll see some little lumpy things, one on this side and one on this side. Those are the palatine tonsils. Don't try to see your lingual tonsils, your tubal tonsils, your pharyngeal tonsils. You'll basically hurt yourself in that exercise, and it's not going to be a valuable experience for you or the bathroom probably. But you can see the palatines, and Those of you who have had really sore throats know that those palatines can enlarge, and sometimes they have gunky looking stuff on them, can have some kind of white pussy looking material on them. What the tonsils actually are just collections, again, of developing lymphocytes. They're very close to the mucous membrane of the alimentary canal, and they produce, again, those developing lymphocytes produce antibodies in response to exposure to foreign proteins. Those foreign proteins we call antigens. Yeah, you had a question, Adam?
Yeah, I've heard people when they're doing it, having their tonsils removed, talk about also having their adenoids removed. What are those?
The adenoids are enlarged pharyngeal tonsils. Let me pull that model back up again, and let's look at it on the overhead camera one more time. These are the ones that I called pharyngeal tonsils here. And when these enlarge and get enlarged due to inflammatory processes, these are called adenoids. A routine tonsillectomy will remove the palatine tonsils right here, and quite often the adenoids are taken out at the same time. Tubal tonsils around the opening of the auditory tube and lingual tonsils down here in the base of the tongue typically are not removed during tonsillectomies. Now, when I was a kid, you had a few sore throats, and they'd schedule you for a tonsillectomy. And when I discovered that, I basically quit admitting to having sore throats. You know, I just kind of sucked it up. But the reality is they lost a few children on the operating table. It's not because the procedure in itself is so inherently dangerous, but it's a little bit difficult back in that region to control the hemorrhage that results from the removal of this tissue. So how many of you have had tonsillectomies? See, none of you, nor have I. But it was kind of a very routine, common procedure when I went through grade school for children to have tonsillectomies, usually as a result of recurring sore throats. And certainly it did improve that situation. Starling?
Does it affect your body at all to have less antibodies produced if you
Well,
remove those?
the total, you know, that's an interesting question. I mean, these are obviously there for a reason. They are producing antibodies. The fact of the matter is all of the tonsillar tissue is not removed. There's still some others that don't get removed in the procedure. And then we have a lot of other antibody-producing tissue in the body besides just these tonsils. So I don't think it's not a significant inroad, at least, into the ability to produce antibodies. The largest lymphatic organ, the largest single lymphatic organ, is the spleen. I want to go to the overhead camera. I've got a model here, but I don't like it very well, so we're just going to look at a drawing. Let's let this be the stomach. Okay? Better label that so we recognize it. We haven't talked about the digestive system yet. But located right along the greater curvature of the stomach is the spleen. I mentioned a while ago it's the largest lymphatic organ, and it contains developing lymphocytes. It actually has some different organization at the microscopic level than some of the other lymphatic organs, but it does have developing lymphocytes within it as well. And I think I did mention that once in a while the spleen can be ruptured by, you know, a traumatic blow. There's a capsule around it. Surgeons will try to suture it back together if it's not severely damaged, but in some cases they're unable to do that, and they'll simply do a splenectomy and remove the spleen in those cases. Sometimes individuals have more than one spleen, which basically is just a developmental anomaly with no clinical significance. The splenic tissue will simply be divided into 2 or 3 smaller segments rather than a single larger organ. The Peyer's patches that I mentioned, or the subepithelial aggregations of lymphatic tissue, are just isolated lymphatic nodules that occur in the submucosal region in the lower alimentary canal. There's a few of them in the small intestine and a lot of them in the wall of the large intestine as we move down the path. I want to talk a little bit about more about the function of the lymphatic system, and to do that we need to get a couple of terms defined. So let's go to a graphic that defines antigen here. An antigen is a protein foreign to the individual exposed to it. In other words, this is a protein that's not found in that individual's body. Now we put foreign in quotes because there are some proteins in our body that our body doesn't even recognize that we have. In other words, the protein within the lens of our eye is foreign to us. And if we crush up a lens and inject that lens material into our own body, we will produce antibodies against it because our body does not recognize it as self, if you will. And there's a couple other places like thyroglobulin within the thyroid gland is actually foreign to your own body. Your own thyroglobulin is foreign to you because that particular material is not exposed to the circulating bloodstream. Well, if that's an antigen, a foreign protein, what's an antibody? Let's look at a graphic here that defines antibody. It's an anti-antigen protein that we manufacture after we've been exposed to an antigen. So both antigens and antibodies are proteins. Adam?
So are antibodies specific to an individual antigen?
Antibodies are specific to an individual antigen. So we have thousands and thousands and thousands of different antibodies because we've been exposed to that many different antigens.
How do the developing lymphocytes within the lymph nodes know which antibodies to produce at a given time?
It has to do with exposure, and of course when you're very young you don't have nearly as many as you do later on because every time that you're exposed to a different antigen you produce antibodies to that particular antigen. I've got some figures that we'll look at here in just a little bit. There's some gee whiz figures on the total numbers of antibodies, different kinds and so forth. Let's go back now, and if we were to analyze the plasma in our body, we'd find, let's go to a graphic here that shows that plasma is about 92% water, about 7% protein, and about 1% other solutes. Now, I want to take a look at just the protein segment here. So we'll look at the next graphic, which will summarize the protein. Protein's about 60% albumins, 35% globulins, 4% fibrinogen, that's the clotting protein, remember, and there's about 1% of other kinds of proteins present. And I want to concentrate on these two just a little bit. If we'd actually take a look at plasma protein and separate it out, let's just clear that graphic but stay on the overhead camera for just a moment. We'd separate out albumins, which we said were about 60%. And then the globulins, there's actually alpha-1 globulins, alpha-2 globulins, there's some beta globulins, and finally we got some gamma globulins, alpha-1, alpha-2, beta, and gamma. These three are primarily transport proteins that involved in transporting things in the bloodstream. But these gamma globulins, that's more or less synonymous with antibodies. And we can actually separate the gamma globulins into, and it's not important that we remember all this, but IgGs and IgAs and IgEs. And there's even some IgMs and IgDs. Most of the circulating antibodies are in fact IgGs. The ones that are circulating in our bloodstream. I'm just going to write AB'(S) for antibodies. Most of the antibodies that are present in saliva and milk and other external secretions are IgAs. These guys give us the allergic or hypersensitive type reactions. And these are primarily involved in antigen receptors that are present on lymphocytes. We'll not worry about those. We just want to kind of give you an idea. When we talk about globulins, that includes all of these. But the alpha-1s, alpha-2s, and betas are primarily transport proteins. It's the gamma globulins that we're talking about when we're talking about antibodies. Yeah, Adam?
When you're given a gamma globulin shot, Does it include all of those, IgA, IgM, or is it just?
As I understand it, there's going to be all of those present in there. Those are. Has anybody here ever received one of those gamma globulins? It wasn't a very nice experience, was it?
No, it actually felt kind of like a 16-ounce can of chunky peanut butter
Yeah.
injected in.
It's pretty thick stuff.
Caused a lump for quite a while.
Let's talk about immunity for just a minute. When we say we're immune to something, that means we either don't get it or we have a tendency not to come down with that particular disease syndrome. When you're first exposed to some infectious disease, like chickenpox, for example, your body starts producing antibodies to that chickenpox virus, but it takes several days to produce antibodies, and you don't produce very many antibodies, and as a consequence, what happens? You typically get chickenpox. We call that initial antibody response, which takes several days to produce and does not result in very large numbers of antibodies. We call that the primary response. Let's look at that graphic. Primary response, antibodies made when first exposed to an antigen, requires days to produce the antibodies, and not very many are produced. As a consequence, even though we're producing antibodies, giving us, quote, immunity to that disease, we're not producing them fast enough. On the other hand, once I've had chickenpox, or you've had chickenpox, if we're exposed to chickenpox again, weeks, months, years later, we will develop what's called a secondary response. Let's look at a graphic on secondary response. Here we're being exposed to an antigen that we've been previously exposed to. We produce antibodies. We produce them very, very quickly, just require hours to get that kind of response, and we produce a lot of antibodies, typically enough antibodies that we do not get the disease a second time. And so that's basically the idea of primary response, secondary response. Now let's take that to practicality. There are some diseases we simply get and then we don't get again, but there are other diseases that we never get because we are vaccinated against them. And so the vaccination process itself gives us attenuated, weakened, or sometimes killed infectious organisms, and we produce antibodies to that particular antigen, and that results in the primary response. But we couldn't develop the disease because the organism was killed or weakened at least, and so we don't get the disease. But then second, if we're exposed to, subsequently to the actual infectious agent in the real world, we have an immediate secondary response, and we're immune. So that's the whole idea of a vaccination. Yeah, Amber?
So if people do by chance get chickenpox twice, is it because they don't produce enough antigens the first time?
It's because they didn't produce, not necessarily the first time, it's because their secondary response, the second time, was not adequate. Every once in a while, the secondary response doesn't produce enough antibodies to prevent the disease happening again. But usually it does, in most cases, and it depends. Adam?
If it happened a second time, would it be a weaker case of the disease?
Good question. I think that is true sometimes because you certainly do have a bunch of circulating antibodies against that particular antigen, so I would presume in many cases it would not be as severe as what otherwise have been. Here's a gee whiz graphic for us to look at. Let's go take a look at this graphic. About 10 to the 20th power antibody molecules in one individual. Now that's a lot of them. I don't know what gazillion that is. Okay? With specificity for a few million different antigens. About 10 to the 20th molecules of gamma globulin with specificity for a few million different antigens. Let's talk about immunity a little bit more. I can't get canine distemper because humans are simply innately immune. You just don't get certain diseases that some animals have. That's called innate immunity. What do we mean by passive immunity? Anybody know what we mean by passive immunity? Seth?
Is passive immunity when, like, you get a shot of gamma globulins and it's not actively acquired, it's artificially
Passive
given?
immunity is when you have some antibodies that are put into your body that you did not yourself produce. And one example that you just mentioned, that Adam previously mentioned, would be a gamma globulin injection. You've got antibodies that may protect you, from exposure to hepatitis, for example. It's a after-exposed type injection that's done. You didn't produce those antibodies, but they're now in your body, and they last long enough in your body to protect you from the disease to which you've been exposed. Another example of passive immunity might be antibodies that would come through the colostrum, the first milk that's produced. There's a period of time when a neonate can absorb intact antibody molecules from the alimentary canal. That's another example of passive immunity. Active immunity is when you're actually producing antibodies yourself, okay? So passive, you've got antibodies that you didn't produce someplace else they were produced, and now you have them. And active immunity, you produce those antibodies. Starling?
I know with smallpox, there were some people that just didn't get it. Or did they have the antibodies that actually could fight it, whereas everyone else didn't?
There's if we're all exposed to a given infectious disease, not all of us will come down with it, and there's lots of different reasons why that can be. Some of us have an immune system that is a little more responsive than the next. That's one factor. Another may be the state of health and things that are going on in our body versus the next person, and so forth. So there is individual variation in that, and not all of it can certainly be explained, I don't think, but it's a well-known observation, certainly. What's an autoimmune disease? Adam?
It's when your body's immune system attacks itself. When it marks certain cells as foreign invaders, loses the ability to recognize them as self cells, and produces antibodies against them.
So it's kind of a serious situation, is it not?
Yes.
Let's go to the overhead camera for just a minute. I just want to write up here immune diseases. And I'm going to put this in quotes. There's kind of three categories of these. And the first one is autoimmune diseases. I'm just going to write D. Immune complex diseases. And allergies. We could say hypersensitivities here. Now, one of the things I want you to remember about all three of these is that they are not caused by foreign pathogens, that they are caused, in fact, by some kind of a failure of the immune system to recognize and tolerate what we call self-antigens. In other words, the proteins that you have in your own body. And I want to concentrate on this one just a little bit. How can we end up with autoimmune diseases? How can we start making antibodies against some of our own proteins? Well, I mentioned a while ago that the protein in the lens of the eye, the thyroglobulin that's within the thyroid gland, before it's broken down and the triiodo and tetraiodothyronine are broken out of it, those proteins are isolated from the bloodstream in our bodies. And our body doesn't actually realize that those particular materials are self. If we have some kind of traumatic incidents that actually, if we get hit in the eye really badly, it shatters the lens, then that lens protein can become an antigen. Our body can start forming antibodies against lens protein, and guess what's going to happen to the other lens of the eye? Those antibodies are going to start attacking that lens protein in the other eye. So same thing can happen to severe traumatic injuries involving the thyroid gland. You can get some of that thyroglobulin released into the bloodstream and actually start producing antibodies against your own thyroglobulin. You can also have some of your own proteins in your body that combine with foreign proteins and complex with foreign proteins, and then your body starts making antibodies against the complex, which then starts cross-reacting with your own protein that's not even complex with that foreign protein. So those are some of the kinds of ways that we can end up with autoimmune diseases. Starley?
Sorry, I know within the RH, the mother could take something so that her body didn't produce those antibodies. Do they do that for other things as well? Or?
There's some of them they can and some of them they can't. When we think about immunity in general, you know, we have some non-specific immunity that everybody knows about, phagocytosis. Everybody knows we have some cells that are phagocytic. We've got fever. You know, when you get an infectious disease, quite often your body temperature goes up, right? So that's what is the physiological advantage of having a fever? Is it good, bad, or? Yeah, Adam?
Aren't you getting the body temperature high enough to interfere with the enzymatic activity of some
That's
proteins?
exactly what's going on. It doesn't take much of an elevation in the body temperature to start interfering with some of the enzymatic processes that those microbial organisms are involved in. Of course, it interferes with some of your own processes, and so you don't really feel very good when you have a fever going on, do you? Interferons are another non-specific kind of immunity. These are proteins that are produced when we have viral infections. It's kind of interesting. If you have an active viral infection going on in your body, you can't get another viral infection for some reason, because that virus, while it's actively involved with your body, is actually producing some proteins called interferons, which prevent other viral infections from getting gaining a foothold. You would think that medical science would have developed the ability then to simply produce interferons and give everybody interferons to prevent viral diseases. Fact of the matter is they can't produce interferons in that large a quantity. They're very complex proteins. So, but those are some of the kinds of things that are involved in this very, very, very complex field of immunity. We're only scratching the surface and beginning to discover some of the things that are going on with the, quote, immune system that we've called today the lymphatic system.